The spinal cord is the long lower part of the central nervous system. It is the main pathway for information connecting the brain and the peripheral nervous system. It gives rise to 31 pairs of spinal nerves and retains the basic structural pattern. It occupies about two-thirds of the vertebral canal. It, it is 45 centimeters in length in adult male and 42 centimeters in adult female. It extends from the upper border of the atlas to the lower border of the first lumbar or the upper border of the second lumbar vertebra in adult. In infants and children, it extends up to the third lumbar vertebra. The spinal cord is surrounded by three meningeal coverings, that is the dura, the arachnoid, and the pia mater. Here in this diagram, you can see the spinal cord surrounded by the pia mater. Here, the two nerve roots, the anterior root and the posterior root, they are given rise by the spinal cord and they join to form the spinal nerve. Here you can see the spinal cord is surrounded by the pia mater, the arachnoid mater, and the dura mater. And these meningeal coverings they fuse with the spinal nerves when the spinal nerve comes out to the intervertebral foramen. And here what you can see is the epidural space between the dura mater and the endosteum of the vertebral canal. Here in this line diagram, you can see the spinal cord surrounded by the pia mater, then this arachnoid mater and the dura mater. Between the pia and arachnoid is a subarachnoid space. Between the dura here and the arachnoid it is a subdural space, and between the endosteum of the vertebral canal and the dura mater here you find this is the epidural space. This pia mater is extends laterally, it is modified here and extends laterally to the arachnoid to join the dura mater. This forms what is known as the ligamentum denticulatum. Below the level of the conus medullaris only, the pia is continued as thin fibrous cord. The filum terminate. The filum terminale is 20 centimeters long. After leaving through the sacral hiatus, it ends by getting attached to the periosteum of the first segment of the coccyx. The dura and arachnoid, along with the subarachnoid space containing CSF, extends up to the second sacral vertebra. Between the lower border of the first lumbar vertebra and the second sacral vertebra, the subarachnoid space contains spinal nerve roots which constitute cauda equina. Dorsal and ventral roots of L2 to L5 and S1 to S5 and coccygeus 1 lie almost vertically around filum terminale. As these resembles horse tail, they are called cauda equina. Here in this photograph, you can see the spinal cord lying in the vertebral canal surrounded by the meninges and Here you can see the conus medullaris, and this is the filum terminale, which extends up to the S2. Then it is surrounded by the nerve roots here, which resembles the horse tail and known as cauda equina. Then cauda equina syndrome. It is a condition when there is compression of the cauda equina, and this presents as peripheral nerve. Most common symptoms urinary retention, post-wide residual urine is more than 100 ml, serial anesthesia, lower motor neuron symptoms, increased flexibility of the lower extremities, and loss of TTRs. Conus medullary syndrome. The most distal bulbous part of the spinal cord, situated at the level of L1 to L2 vertebra bodies and comprises of sacral segments of S1 to S5. The sign shows involvement of saddle anesthesia because of involvement of S3 to S5 nerves, absent bulbocavernous reflexes because of the involvement of S2 to S4 nerves, absent anal reflexes again because of involvement of S4 and S5 nerves. Symptoms include both upper and lower motor neuron lesions, lower motor neuron at the level of the compression and upper motor neuron lesion below the level of the compression. So here you can see the upper motor neuron lesion, and here you can see the lower motor. Enlargements in the spinal cord. The spinal cord shows two enlargements, and these enlargements are because of the more motor neurons which supply to the limbs. So these swellings, they are present at the level of the cervical region, which extend from C5 to T1 segments to form the brachial plexus. Its widest significance circumference is 38 millimeters at C6 level. Second enlargement is at the lumbosacral level, that is at the level of the lumbar plexus. It extends from L2 to S3 level to form the lumbosacral plexus. It is widest significance circumference is 35 millimeter at S1 level. Segments of the spinal cord. The part of the spinal cord giving origin to one pair of spinal nerves constitutes one spinal segment. It does not correspond to the corresponding vertebra. The spinal nerves appear to ascend to the level of the lower border of third lumbar vertebra at birth and at the lower border of first lumbar vertebra in adult. Relation of the spinal segments with the vertebra. Vertebral body is always lower than corresponding spinal segment. To get the level, at one segment for cervical region, at two for upper thoracic region, at three for T6 to T9 vertebra. Lumbar segments extend from lower border of T9 to lower border of T11. Sacral and coxillary segments extend from T12 to L1 vertebra. In this diagram, you can see the various levels of the spinal nerves and the vertebral uh, and the vertebra, and which has been corresponded here with the vertebra epidural space. The spinal cord is enclosed only by meningeal layer of the dura mater. The space between the meningeal layer of the dura mater and the endosteum of the vertebral canal is called epidural space. This space is occupied by adipose tissue and network of blood vessels. The epidural anesthesia is given in this space. Here in this diagram, you can see the spinal cord surrounded by the meninges, that, that is the pia, arachnoid, and dura. Here you can see this is the dura mater, white one, and this is the epidural space. The needle has been placed here in the epidural space to give anesthesia. This is a very common clinical procedure which is done to anesthetize low, the lower segment of the spinal cord in the cases of the delivery. Then lumbar puncture is another medical procedure. The subarachnoid space lies between the arachnoid and the pyometer and is filled with CSF. The medical procedure known as lumbar puncture or the spinal tap involves the use of a needle to withdraw CSF from this space. As the spinal cord extends up to the lower border of L1 vertebra in the adults, the lumbar puncture is done in the interval between the L2 and L3 vertebra. In infants and children, the lumbar puncture is done below lumbar C vertebra because spinal cord extends up to the L3 vertebra. Here in this diagram, you can see the needle has been put in the subarachnoid space here. Here in this is the subarachnoid space between the pyometer and the arachnoid mater. Now, this is procedure is done to tap out the CSF to diagnose the various clinical conditions related to the central nervous system. The procedure is done has been done here in the vertebral level between the L3 and L4. The needle pierces the skin, the subcutaneous tissue, the back muscles, the supraspinous ligament here. Then you can see it pierces the interspinous ligament, then ligamentum flavum here, and then epidural space to reach the subarachnoid space. It is done here at the level of L3 and L4 to avoid any injury to the spinal cord. Ligamentum denticulatum. There are 21 pairs teeth like projections of pyometer which fuse laterally with the arachnoid and dura mater midway between the exit of the roots of the adjacent spinal nerve. The highest process attaches immediately superior to the foramen magnum. It, this ligamentum denticulatum keeps the spinal cord in position. In this diagram, you can see that ligamentum denticulatum, which is a modification of the pyometer with, between the two roots, that is the dorsal and the ventral root. Here you can see the dorsal root, the ventral root lies anteriorly, and it lies, the ligamentum denticulatum lies between the dorsal and the ventral root. It extends laterally through the arachnoid and the dura mater. This is the arachnoid and this is the dura mater. And this keeps the spinal cord in position. Filum terminate. It is a modification of pyometer, 20 centimeter in length, and after leaving through the sacral hiatus, it ends by getting attached to the periosteum of the first segment of coccyx. It consists of two parts: filum terminale internum, which is the upper 15 centimeter part, which extends up to the second sacral vertebra; filum terminale externum. It is the lower part of the filum terminale, which lies outside the dura mater and attaches to the first segment of the coccyx. Here you can see the conus medullaris, the spinal cord surrounded by the pyometer, and here you can see the filum terminale. You can appreciate that subarachnoid space extends up to the filum terminale internum, which ends at the level of S2 vertebra. Beyond that, there is no subarachnoid space, only the pyometer extends up to the coccyx 1. So the filum terminale, which is composed of pyometer, extends from the conus medullaris to the coccyx. Note that the subarachnoid space also continues from for some distance, that is up to the S2 vertebra. Then few clinical conditions which are related. One is the poliomyelitis. It is a viral disease which involves anterior horn cells, leading to the flaccid paralysis of affected segment. It is a lower motor neuron type of paralysis. If the poliomyelitis affects the upper cervical segments of the spinal cord, it may be fatal because of the involvement of C4 segment, which supplies the diaphragm to the phrenic nerve. Here you can see the patients of the poliomyelitis which are affected here, where deformities of the lower limb or the upper limb are seen. Another condition is the tabes dorsalis. It occurs during the tertiary stage of the syphilis. There is a degenerative lesion in the dorsal nerve roots and the posterior white columns. Its feature is severe pain in the lower limbs as the disease occurs in lower thoracic and the lumbosacral segment. The lower limbs are mainly affected. Here in this diagram you can see the case of the tabes dorsalis. This is the involvement of the dorsal column of the spinal cord and the dorsal root. It results into the loss of position and vibration sense below the level of the lesion. So here the lesion is at the T8 spine level. You can see here. With the eyes closed, the patient tends to fall. The feet they are get uh, together. Then come to the internal structure of the spinal cord. Contrary to the cerebrum and brainstem, the white matter lies in the periphery and the gray matter lies in the center. So in the central nervous system, everywhere we find that gray matter lies at the periphery and the white matter lies in the center. But here, contrary to the uh, cerebrum and the brainstem, the white matter lies in the periphery and the gray matter lies in the center. In the center of the gray matter is the central canal lined by ependyma and filled with CS. The gray matter is in the form of H with a gray commissure joining the gray matter of the right and the left side. The gray matter comprises an anterior and a posterior horn. Only in T1 to L2 segments and S2 to S4 segments there is a lateral horn. Here in this CS of the spinal cord, you can see the gray matter which is present, which is S-shaped, and it is present centrally. This H-shaped gray matter surrounded by the white matter. Now, this gray matter has got two horns, right and left, joined by the gray commissure here. Each gray matter has got a posterior horn and an anterior horn. In the T1 to L2 segment, you can find here a lateral column. This is also present at the level of S2 to S4. Here you can see the white matter, which is divided into a posterior column here, a lateral column between the anterior and the posterior root, and an anterior column between the anterior median fissure and the anterior. This posterior column here, you can see it is present between the posterior median sulcus and the posterior. Here you can see the variations in the appearance of the transverse section to the various levels of the spinal cord. You can see here in the sacral region the white matter is less. In the lumbar region it increases in size, more so in the thoracic than in the lower cervical and in the upper cervical. So as you go from below upwards, the white matter increases. Another, in another way, in the upper segments, that is upper cervical region, more of the motor nerves are present, which leave in the lower cervical segments at the because at this level is attached the brachial plexus. Then you can see lower down here in the lumbosacral region again there is sudden decrease in the white matter because of the lumbosacral plexuses. Then nuclei of the spine. The anterior horn is motor in function. The lateral horn has visceral afferent and efferent in function. The posterior horn is sensory in function. Here in this diagram, you can see the anterior horn having medial motor nucleus, the lateral motor nucleus, here, the intermediolateral, and here you can see the intermedial. Here the dorsal nucleus of the clot. The posterior column you can see here the marginal bone, the substantia gelatinosa, the nucleus proprius, and the dorsal nucleus of the clot. Here on the right side, another way of uh, classification seen that is in the form of lamina. There has been demarcated out 10 lamina in the uh, pyramid. The anterior half, it is motor, having a ventral part, the head, and a dorsal part, the base. It innervates the skeletal muscles. It has two groups of nuclei, medial group present throughout the and innervates the axial skeleton. The lateral group, it is present in cervical and lumbar enlargements and supplies musculature of the limbs. Nuclei in the lateral. The lateral hand shows in two nuclei, that is the intermediolateral nucleus and intermediomedial nucleus. Intermediolateral nucleus acts as both efferent and afferent nuclear column and seen at T1 to L2 segments, that is the thoracolumbar outflow. It consists of preganglionic sympathetic fibers and S2 to S4 segments containing preganglionic parasympathetic fibers. The intermediomedial nucleus, it is mostly containing the internuncial neuronal column. Then coming to the nuclei in the posterior horn. Posterior horn has got four groups of the nuclei. The posterior marginal nucleus, the substantia nigra, the nucleus proprius, and the nucleus dorsalis. The posterior marginal nucleus receives dorsal root fibers. The substantia gelatinosa carries the pain and temperature sensations. The nucleus proprius, it is associative. It has got associative mechanism. The nucleus dorsalis, it relay column for the reflex or the unconscious proprioceptive impulses to cerebellum, and its axons give rise to the posterior spinocerebellar tract. Here you can see the various nuclei in the anterior horn, in the lateral horn, and in the posterior. Then coming to the tracts, that is the white matter. The tracts are defined as collections of nerve fibers which have same origin, course, and termination. They are descending tracts and ascending tracts. The descending tracts, there are two types, pyramidal and extrapyramidal types. The ascending tracts, they are the sensory tracts. Here In this diagram, we can see the arrangement of the ascending tracts and the descending tracts. The descending tracts, they consist of the lateral corticospinal tract, the lateral corticospinal tract, the rubrospinal tract, and the lateral reticulospinal tract present in the lateral funiculus. Then you find the ventral corticospinal tract, the vestibulospinal tract, the tectospinal tract, and medial reticulospinal tract present in the anterior funiculus of the spinal cord. Then here you can see the sensory tracts. Sensory tract. So in the posterior column you see the fasciculus gracilis lies medially and fasciculus spinatus lies laterally. The in the lateral column here you can see the dorsal spinocerebellar tract, the ventral spinocerebellar tract, and the lateral spinothalamic tract. In the anterior column funiculus you see the ventral spinothalamic tract. So that way you can see that posterior funiculus is mainly sensory, lateral funiculus is mixed having both the motor and the sensory tracts, and anterior funiculus is predominantly motor. The descending are the motor tracts. They consist of and pyramidal fibers, that is the pyramidal are the corticospinal tract. Pyramidal tracts they are anterior and lateral. The extrapyramidal tracts they consist of the rubrospinal, the tectospinal, vestibulospinal, olivulospinal, and reticulospinal, that is medial and lateral. Here the motor tracts they have been shown in this diagram. You can see here the lateral corticospinal tract and the rubrospinal tract. In the lateral spinal tract, corticospinal tract, the distribute the presentation of the body is from anterior to posterior. If you see, it is arm, trunk, that is the thoracic part, the abdominal part, then the lower limb, then here surrounding the clear matter you can see the intersegmental tract present at all the levels of the spinal cord. Here, this pathways of the corticospinal tract and corticonuclear fibers, you can see they arise in the cerebral cortex in the motor area. Then the fibers they descend now in the form of the corona radiata, which converge further to form the internal capsule between the thalamus and head of the cortex nucleus medially and the lentiform nucleus laterally. Now, from the internal capsule, the fibers that descend down here in the crus cerebri of the midbrain, then they pass through the basilar part of the pons, then they lie in the pyramid, in the lower part of the pyramid of the medulla oblongata, the corticospinal fibers that decussate and they cross to the opposite side. Here you can see it's crossing from the left to the right to form the corticospinal tract. About 80% fibers they cross. Remaining 20% fiber pass ipsilaterally as anterior corticospinal tract, which as the fibers descend down, they cross to the contralateral side. Both these fibers they are relayed here in the anterior horn. The second order neuron, also known as motor neuron. The first order neuron is known as upper motor. Lower, the second order neuron is known as the lower motor. So the neuron which is arising from the cerebral cortex to the anterior horn, it is the upper motor. From the anterior horn to the periphery, it is the lower motor. They pass in the anterior root with the spinal nerve, then they are distributed to the periphery. The corticonuclear fibers they are relayed here in the brain stem and pass in the cranial nerves. Here you can see the rubrospinal tract here arising in the red nucleus of the midbrain. It originates here in the red nucleus, travels in the lateral column, terminates on the international neurons in the spinal cord. It is largely cross-tracked. It controls the distal limb muscles. It stimulates flexors and inhibits the extensors. Then tectospinal tract. The tectospinal tract arises from the superior colliculus here. Superior colliculus of the midbrain. The nerve fibers they cross the midline here in, in the dorsal tegmental decussation. Then they descend close to the medial longitudinal bundle. In the pons, it terminates in the anterior gray column of the upper cervical segments of the spinal cord. It is responsible for the reflex movements of head and neck in response to the visual stimuli. Then vestibulospinal tract. The vestibulospinal tract it arises from the lateral uh, vestibular nucleus axons that descend ipsilaterally in the ventral funiculus. They terminate on the ventral horn cells throughout the length of the spinal cord. It has excitatory influence upon lateral motor neurons. It controls extensor muscle tone in the anti-gravity maintenance of the posture. Olivospinal tract. Also, it is called bulbospinal tract or the tract of Halbach. It arises from the inferior olivary nucleus, descend down in the anterior part of the lateral right funiculus. It terminates in the anterior horn cells of the spinal cord. It is found in the cervical region only. Its function is the reflex movement arising from the proprioception. Then the reticulospinal tract. There are two reticulospinal tracts, the lateral and the medial. The lateral reticulospinal tract arises from the medial medullary part of the reticular formation and the fibers run down in the lateral right column, largely intermingled with the corticospinal fibers. Its influence on the anterior horn cells is facilitated The medial reticular spinal tract comes from the cells in the pontine reticular formation. It descends down in the anterior horn, white column, to have an inhibitive action on the motor neuron. Then coming to the sensory tracts. So before discussing the sensory tract, we will give a brief note about the sensory receptors. The sensory receptors are peripheral nerve endings of the afferent nerve fibers which receive impulses and known as receptors. Functionally, they are classified as extoreceptors, proprioceptors, interoceptors, and spatial sense receptors. The extoreceptors they respond to the stimuli from the external environment, that is pain and temperature, touch and pressure. The pain and temperature is carried by the lateral spinothalamic tract, and the crude sense and pressure is carried by the anterior spinothalamic tract. Then proprioceptors. They respond to the stimuli in deeper tissues, that is contraction of muscles, movements, position and pressure related to the joints. These are responsible for coordination of muscles, maintenance of the body posture and equilibrium. These actions are perceived both at the conscious and unconscious level. They are carried, the fasciculus gracilis carries proprioceptive sensations from the lower thoracic, lumbar, sacral, and coccygeal segments of spinal cord, while the fasciculus cuneatus carries this proprioception from the upper thoracic and cervical segment. So the posterior funiculus has got fasciculus gracilis and fasciculus cuneatus. Fasciculus gracilis it is for the lower part, that is the trunk and the lower limbs, and the fasciculus cuneatus is for the upper thoracic and cervical. Then reflex proprioception. It is carried by dorsal and ventral spinocerebellar tracts. They convey cerebellum both extroceptive, that is a touch, and unconscious proprioceptive impulses arising in the Golgi tendon organs and the muscle spindle. These are essential for the control of posture. The spino-olivary and spinotectal tracts are responsible for proprioceptive and visual reflexes. Then interoceptors are extroreceptors. These include receptors and organs present in the wall of the viscera, gland, blood vessels, and specialized structures in the carotid sinus, carotid bodies, and osmoreceptors. They carry sensations of hunger, nausea, and pain. The spatial sense receptors, these are concerned with the vision, hearing, smell, balance, and taste. Then ascending tracts. For protopathic sensations, it is carried by lateral spinothalamic tract for pain and temperature, and spinothalamic tract for crude touch and pressure. The for proprioceptive sensations is fasciculus gracilis and fasciculus cuneatus. They carry tactile, localization, and discrimination. They also carry conscious proprioceptive fibers. For reflex proprioception, that is, you find two tracts, that is the dorsal, that is the ipsilateral fiber, and ventral, that is the bilateral fiber. So there are two, that is the dorsal and ventral spinocerebellar tracts. They are concerned with the reflex proprioceptive impulses to the cerebellum perceived at the unconscious level. This TS of the spinal cord shows the sensory tracts, that is the fasciculus gracilis and fasciculus cuneatus in the posterior funiculus. Then in the lateral funiculus, you see the anterior and posterior spinocerebellar tract, then anterior spinothalamic and lateral spinothalamic tract. Here you can see the pathway of the fasciculus gracilis and fasciculus cuneatus. The, as you know, this pathway is concerned with the proprioception that both these tracts they are present in the dorsal column. They convey well localized touch, pressure, and vibratory sense from legs, that is the fasciculus gracilis, and from arms, that is the fasciculus cuneatus. The fibers they arise from the present in the dorsal root of the spinal nerves. They come here in the dorsal column, dorsal funiculus. The second order neuron, you see, they arise in the nucleus gracilis. They form the internal arcuate fiber. So these fibers they cross to the opposite side and they ascend up as medial lemniscus. So the medial lemniscus has got the second order neurons. They ascend up to the pons through the midbrain to reach the thalamus. That is the ventral posterolateral nucleus of thalamus. And from here, the third order neurons they arise and they pass as to the cerebral cortex as thalamic radiation. From the fasciculus gracilis, the thalamic radiations they go to the postcentral gyrus. They carry the lower limb. The fasciculus cuneatus they carry they present in the cervical region. They enter the posterior root of the spinal cord. The fibers they ascend up. They relay in the nucleus cuneatus. Second order neurons. The nucleus cuneatus present in the medulla oblongata. The second order neurons. They, that is the internal arcuate fibers. They cross to the opposite side. That is the sensory decussation and ascend up as medial lemniscus. The second order neurons are present in the medial lemniscus, which passes through the pons which passes to the pons and the midbrain. The lateral lemniscus here, it terminates in the thalamus. The third order neurons, they arise from the ventral posterolateral nucleus of the thalamus, and they pass to as a thalamic radiation, and they carry the upper limb sensations to the postcentral gyrus. Then the lateral spinothalamic tract, which carries the pain and temperature impulses. The input is from the free nerve endings and the thermal receptors. They transmit it to the spinal cord, to the delta A and C fibers. The central processes they enter the spinal cord to the posterior nerve root and proceed to the tip of the dorsal gray column. The second order neurons, they lie in the dorsal horn, cross to the opposite side. They decussate here, ascend in the contralateral ventral column, and in the ventral posterior nucleus of the thalamus. The third order neuron, they arise in the ventral posterolateral nucleus of the thalamus, and they project to the cerebral cortex of the area C12. So here you can see the pain and temperature fibers from the free nerve endings and thermal receptors. They come in the dorsal root, they cross to the opposite side, they pass as a lateral spinothalamic tract, they ascend up, and here to the uh, medulla, to the pons, to the midbrain. They reach to the thalamus. From here, the fibers they pass in the thalamic radiation to the cerebral cortex. Anterior spinothalamic tract. It carries the light touch and pressure impulses. The inputs, they are from the free nerve endings, that is the Merkel's tactile disc. The first order neurons, they lie in the dorsal root ganglion at all the levels. The second order neuron in the dorsal horn cross to the opposite side. They decussate and ascend in the contralateral ventral column. They end in the ventral posterolateral nucleus of the thalamus. The third order neuron in the ventral posterolateral nucleus of the thalamus project to the cerebral cortex, area 312. So here you can see the passage of the anterior spinothalamic tract. Then the spinocerebellar tract. The spinocerebellar system consists of a sequence of only two neurons. That is, and there are two tracts, that is, a posterior and anterior. So the sensory tracts, they are of two types. That is, a three or neuronal tracts and two neuronal tracts. Three neuronal tracts, they are concerned with the protopathic sensations, that is the proprioception and pain and temperature. While the spinocerebellar tracts, they are two neuronal. They consist of two tracts as the posterior and the anterior. They are located near the dorsolateral and the ventrolateral surface of the card. They contain axons of the second order neuron. They carry information derived from muscle spindle, Golgi tendon organs, and tactile receptors to the cerebellum for the control of posture and coordination of movement. Here in this diagram you can see the anterior and the posterior spinocerebellar tract. The anterior, there are two order neurons. The first neuron, it lies in the dorsal root that relays in the posterior horn, and the second order neurons, they pass in the posterior spinocerebellar tract through the inferior cerebral peduncle to reach to the cerebellum. While the anterior spinocerebellar tract traverses a longer course, the fibers, they cross in the spinal cord, they ascend up to the spinal cord, medulla oblongata, pons, and midbrain, and to the superior cerebral peduncle, they reach to the cerebellum. Then coming to the intersegmental tracts, these are formed of fibers connecting various segments of the spinal cord. These are present in the anterior, posterior, and lateral columns of the white matter, adjacent to the gray matter of the spinal cord. The tracts of Lissor is also an intersegmental tract. In this diagram of the TS of the spinal cord, you can see the intersegmental tract lying at the periphery of the gray matter, all around in the anterior funiculars, the lateral funiculars, and in the posterior. Then some clinical conditions which are related to the spinal cord. Number one is the amyotrophic lateral sclerosis. It is a degenerative disease due to damage of the ventral horn cells. The patients present with the weakness and atrophy of the muscles of the hand and arm. Later on, weakness and atrophy extend to the lower limb. In this diagram, you can see the motor neurons of the spinal cord transmit the muscle information to the muscles and receive commands of brain to movements. This is the normal condition. In amyotrophic lateral sclerosis, you can see this command is decreased, and because of the decrease in this command is atrophy of the voluntary muscles. Then subacute combined degeneration of the spinal cord, that is SACD, which means the involvement of the posterior column plus or minus, that is the pyramidal signs. So both the signs, they may be present, either posterior column signs or pyramidal signs or both. SSD, SSCD plus loss of the jaw. If it is associated with the loss of the ankle jar, then it presents the vitamin B12 deficiency. If SSCD is associated with loss of the ankle jar, and as the Robertson people, it is known as Tabes dorsalis. Then SSCD associated with loss or ankle jar plus pes cavus or scoliosis in a young patient, then the syndrome is known as Friedreich ataxia. Here, in this myelin stent section from the lower cervical spinal cord, this is the normal section. You can see the white matter is very well stained, and this is the patient. Here you can see there is degeneration. There is no staining. The lesions, the subacute combined degeneration involves degeneration of the white matter in the posterior and lateral funiculi of the spinal cord. The degenerated fibers lose their myelin and hence they are unstained. So these are the unstained area in the posterior funiculus and in the lateral funiculus. Posterior funiculus, that is involving the fasciculus gracilis and fasciculus cuneatus. The lateral funiculus, it is involving mainly the spinothalamic tract. Then Brown-Sequard syndrome. This is because of this is the hemisection of the spinal cord because of trauma, because of the gunshot, stabbing wound, there is a tumor, spinal cord tumor, there is ischemia or infection. The patient presents with the ipsilateral loss of motor, vibration sense, and uh, proprioception and contralateral loss of pain and temperature sensation. Here, the ipsilateral loss of motor, vibratory, and proprioception. Then syringomyelia. It is a slowly developing disease of the spinal cord. A narrow cavity forms in the cord near the central canal and gradually becomes larger. The lesion typically extends through the middle and the lower cervical and the upper few thoracic segments of the spinal cord, which serves the upper limb, especially the hands. So you can see the small cavity, it extends and led to the periphery, involves the motor and the sensory tracts. And symptoms, they are according to the involvement of the tract. Then the complete spinal cord injury is the most severe form of injury. All sensations, motor and motor functions will be lost beneath the level of the injury. The signs and symptoms that depend upon the level of the injury. There is a quadriplegia or the tetraplegia if the injury is from C1 to C8 level. It presents with the paraplegia if the injury is from T1 to L4 level. Then spina bifida. It is a condition when the two halves of the vertebra that does not fuse and the spinal cord along with the meninges may protrude out. So there are three categories, that is the spina bifida occulta when the gap is filled up by fibrous tissue, meningocele when the meninges they protrude out, and meningocele, myelomeningocele when the spinal cord along with the meninges that protrude from.